Welcome back to the Better Birth podcast. I'm Kathryn, the founder of Anja Health, and today I'm super excited to chat all things lactation and also healthcare and maternal health access with midwife Trinisha Williams. Super excited to have you here today. Thank you so much for being here.
Thank you so much for inviting me here and giving me an opportunity to talk more about midwives and midwifery. I love it.
Yes, that's awesome. Would you like to give a bit of brief background on yourself, how you got involved in midwifery, and what you like most about it?
Sure. So I've been a midwife for about 21 years. I'm a certified midwife, and most of my experience was in a hospital. The last 8 years, I've been doing home birth, and recently, the last 2 to 4 years, I've been working at a birth center. I'm in the process of creating a birth center here in New York City.
Wow.
And what brought me into midwifery was my sister. She became pregnant, and I was first her labor support doula. And at that time, I was getting my master's in public health. And after I completed it, my nephew was born. And I was like, what could I do that's more clinical in regards to birth? And then I heard about the midwives, particularly at one hospital here in the New York City area. And then I applied to midwifery school, and the rest is history.
Wow, that's awesome. So you're starting your own birth center.
Yes.
Oh, cool. Where will it be?
Well, I want to place it in Brooklyn, New York. There are a lot of challenges in the New York City area about birth centers. We haven't had a great history of, regarding birth centers. Some of it is the finances in New York in terms of how much it costs to operate one. Others of it is the policies behind opening a birth center and some of the documentation that needs to happen that doesn't make it really helpful for the process.
Okay, interesting. So how do you want your birth center to differ from others?
Well, the biggest part is that we're going to have midwives that are BIPOC so that they can meet the needs of birthing people.
Right.
Particularly, we are aware of the maternal disparity that Black women are more likely to die from preventable causes by 3 to 4 times than their white counterparts.
Right.
So we will have midwives of color that will lead the charge. It doesn't mean we won't care for other ethnicities or Caucasian or anything else that's out there, but we really want to try to cater to those needs. And since I'm from that culture and I understand it, I want to be able to give what I can to my people.
Wow, that's so awesome. Yeah, I remember reading, I don't know if that this is still true, but I think New York State, it's actually, the disparity is even worse. I think I remember reading like in New York City, it's 12 times as likely if you're Black.
Yes.
So yeah, that's really awesome that you're doing that.
And we don't have enough midwives of color, so that's always going to be a little bit of a challenge to find enough to be able to give care to those birthing people. But I feel confident that once we get the facility open, we'll be able to do that. And your viewers can help us out if they want by going to my website, havenmidwifery.org.
Cool.
You can always make a donation. We are a 501c3, so it's taxable.
Okay.
Deductible. Deductible.
Yes.
Yeah, I was like, what's that mean? That's what I meant to say. And we encourage folks that want to get involved, or if you know somebody that wants to help, we have an info tab there. So let me know about what you want to do to help support us. We need help. We need to make this happen.
Okay, awesome. I'll definitely clip that and promote it. Cool. I noticed you say birthing people. Do you feel like that's the best gender neutral term? I've been kind of like, I've said it before and I've gotten comments like, oh, it makes me feel like less feminine to be referred to as a birthing person, or so is that your like general term of choice?
I do, because of the BIPOC and people who identify as LGBTQ or other types of people don't necessarily want to identify pregnancy as being only women or pregnant or even, breast and other things like that. So it's a language that most people feel comfortable with. However, I'm open to, if a person wants me to, call them, I don't know, a mother or something like that, or some other word, or, that makes them feel more safe, then I'm willing to change. But in general, I want to be inclusive of all people.
Right.
And it does take a little bit of work to recognize the difference in the language, but I'm trying to be aware of what others feel when we use certain words that may not make them feel included.
Yeah, definitely. Yeah, I've been saying birthing person as well, but I always get a lot of comments around it. So it's interesting. Okay, cool. Well, obviously at Anja Health, we do cord blood banking. So I'd love to get your take on it. But in general, cord blood banking is unfortunately not covered by insurance unless the child is tested positive for some kind of disease that indicates that cord blood would be necessary. There are also some genetic testing companies like Billion to One that will cover the first year of cord blood banking if, for instance, you test for sickle cell anemia or something like that. I'm curious what your thoughts are around healthcare that is not covered by insurance, and how can we ethically inform and market those kind of products?
Well, I always have a lot of caution when I talk about health insurance carriers, and that's because I do recognize that we're in the United States of America, in which we have a lot of monopolies and a lot of capitalism. But I've been a childbirth educator since about 2000 when I was certified through Lamaze International. And in my childbirth classes, we used to talk a lot about cord blood banking, and that's one reason why I was curious. When you reached out to me and wanted to talk about certain things, is that I would encourage families to really pursue cord blood banking. But the challenge is, unless you have the funds, it's cost prohibitive.
Right.
We're talking a nominal fee to set it up and then a monthly installment. And most times for most people, they would not necessarily yield the benefits unless they have some, like you're mentioning, genetic or something that's going on that's allowing them to really need to bank it. But I always tell people, if you have the money, do it. It cannot hurt you. I am not happy that health insurance carriers don't want to cover it, but this has been a conversation for over 20 years. And do I think they're going to change? No, because they say it's experimental and all the rest of that stuff.
Yeah, preventative.
Any way to not want to pay for it. But I do think that if the families do have money, that they really should consider it. Those stem cells are they're going to be used for other things as we get better with technologies. And I'm quite sure you'll mention some, great reasons why we should do it. But the only thing for me is cost. I don't see it hurting people at all. In the past, I have collected samples at births, whether it was home birth, hospital, or whatever, and then call the UPS or FedEx to come pick it up to be able. So we call them to be able to pick up the cord blood in order to be able to send it in to the company to be processed. I did have a handful of clients that actually did send in the cord blood, and for some odd reason, it was not enough sample to store, or when they wanted to use it, it wasn't the proper way for some odd reason. Not really sure what that's about.
Yeah, if they do like really extended delayed cord clamping, or if the umbilical cord is really short, or sometimes we really encourage parents to milk the cord just to make sure they can like maximize the cord blood that they're collecting. We try to get like 40 milliliters or less, or 40 milliliters or more.
Yeah, but I'm an advocate that thinks that we need to do this. I don't know how we can lobby insurances to cover it. Or have more affordable banks like you're doing? I don't know.
Yeah, so it's really interesting. I think I've chatted with folks that work in insurance, and generally, I think it's just not to their advantage health economics wise to cover preventative care, and cord blood banking is definitely seen as something that's preventative care. It's something that in the future I definitely want to help lobby for insurance coverage with cord blood banking and just preventative care in general. I feel like if the US covered more preventative care, then we would probably experience less health issues, but that's kind of why I think health insurance companies aren't incentivized to cover it. It's definitely interesting, but I want to advocate for it in the future. But yeah, so you mentioned you have collected cord blood before. How did the process go for you? Did you find it to be easy, especially if you're doing a home birth? How did you just prepare for that?
It's so easy. I mean, I literally open the kit and I look at the instructions, and usually have a colored tube. Yeah. Usually it's anywhere between 2 to 4 tubes. They have the needles there, and we know how to draw blood, so you just put the needle and draw like nothing. And you need to get a sample usually from the mother.
Yes.
Some companies I've seen once in a while the father too, but mostly just the mother. I don't know what they were looking for when they needed one from the father.
Yeah, we've never done that. Have you collected cord tissue in the placenta as well?
No, that's a new
interesting.
one.
Yeah, so we collect cord tissue in the placenta. So basically, not a lot of people know this, but the umbilical cord as well has stem cells, and the placenta. So we also have jars. So we try to cut off around up to 10 inches of the umbilical cord itself, and we'll process the tissue. And then the placenta too, especially because the placenta is so large in volume and size, we're able to collect a lot of stem cells from it. So yeah, we do cord blood, cord tissue, and the placenta. So especially for parents, if parents are currently pregnant and then they give birth and their cord blood volume, for instance, is really low inside of the umbilical cord, then at least they can make sure that they were able to capture stem cells at that pivotal moment from the cord tissue and placenta. So our most popular option is to do all three, because then parents always have all those options.
I'm curious, do you guys ever collect just randomly any placentas to be able to get more cord blood at all? Or is it just specifically donor directed from someone requesting?
Yeah. Well, we never get cord blood from the placenta per se, but you can collect stem cells from it. It's usually the parents themselves wanting to save it for themselves as well. So they'll save the cord blood, cord tissue, and placenta. So, for instance, a story that I talk about a lot is this young boy, Quentin, who was 15, diagnosed with leukemia, and his younger sister had her cord blood and placenta stem cells stored. And so they were able to sort of like, in a way, make the treatment more potent by using both. So after he received like chemotherapy for his leukemia, then they were able to help regenerate his immune system at a much faster rate by using the cord blood and placenta stem cells. And then the placenta stem cells have been used alone, for instance, for like spina bifida or things like that. In general, like with the physicians on our medical board, for instance, are really bullish on the idea of if you're pregnant, you should definitely store your placenta stem cells because it's just so large in volume, and the placenta is just such a powerful organ that generally like our medical advisors are really keen on the placenta in the future being like a really, really powerful resource, potentially even more so than the cord blood.
It will once we figure out how to unlock the codes of what's going on there. I agree with you.
Yeah, definitely. Yeah, I feel like there's so much that's unknown about the placenta. It's crazy.
You know why? I think because there's no money to be made into research on it. And until we find a way to be able to hone in on the funds that are there, I think most companies won't invest in that type of research.
Right. It's so funny. Whenever I'm at healthcare events, if I meet a young man, I'll usually ask them if they know what a placenta is. And usually the answer is no, which is crazy because they had one and it helped them. It's always funny.
Well, that's always a conversation that we should definitely consider having, is that we aren't educated about our bodies and what happens in the whole maternity cycle and birthing. And it is a little bit, most people are not aware.
But what are the pros and cons of cord blood banking in your eyes? I know you mentioned the cost is definitely a potential con, but what pros have you seen and why do you encourage parents to bank cord blood if they're currently pregnant?
The big pros are in the future. I mean, I don't know, it's limitless. I feel as though at some point we'll be able to make organs and all the rest of that stuff, not just, cure certain, diseases like, maybe some diabetes or stuff like that, or help with certain cancer-based, infection diseases. But I don't tell parents that it's a limit on it because I don't know where the research is going. I mean, I feel like at some point we'll have it. And if you had it stored, it'll be able to help yourself, if not maybe the next generation.
Right, definitely. I wanted to get your reaction in particular to this article. Sorry, I forgot to put the screenshot here. But basically it's about stem cells from the umbilical cord being utilized in a cord blood treatment and then delaying type 1 diabetes progression. And in 2012 as well, they were able to even see the reversal of type 1 diabetes by using cord blood. So what's your general reaction to that idea?
I am not surprised. I do believe that the placenta holds a lot of secrets and the cord blood. I do believe that it will be able in the future to cure a lot more things. We just don't know how to harvest that.
Right.
And I'm not surprised at all. Maybe some other people are, but it's an autoimmune. Like I'm grateful that they have the technology and they've figured it out. I think this is wonderful. And I know in the future we're going to have more things. And that's why I was always so saddened that more families couldn't afford to store it until we catch up with what those things we can use from that storage.
Right, right. Yeah, definitely. Yeah, that's why we definitely want to try and have affordable options. Of course, it's still out of pocket. So, we'll see. Cool. Well, my last question is if you have any questions for me around cord blood banking.
Well, the thing you mentioned earlier was about having some sort of law or some sort of policy change to be able to make it more affordable. And I think that's where the key comes in. And what other grassroots organizations can you get behind to be able to lobby something federally? Because otherwise you'll be going state to state. If it was a federal thing, then it can kind of trickle down.
Right.
And who would get behind you on that? I do know I'm involved with another organization that does testing for certain genetic disorders in children. And I know that they would be supportive of something like this. I think it's EWB Foundation.
Okay.
And
awesome.
I know that because this would help them too, because then when their children are diagnosed with different things, it would be able to help them.
Right.
But it's how do you connect all the grassroots organizations that are more national focused, not locally based, and then get some elected officials behind us, because we know how our bureaucracy can work at the federal government.
Yeah. No, it's actually crazy because in 31 states, there is some sort of regulation around informing parents around cord blood banking. So it has reached like elected officials to some degree that it is really important that you freeze stem cells from your umbilical cord and placenta right at birth, or at least that parents know about it. Because, for instance, I always get a ton of comments on my TikTok when I talk about cord blood banking around like, I gave birth last week, no one told me about this. And just so many parents go without ever even knowing about it as an option. And I think a lot of them would potentially freeze their stem cells if they did know about it. I think it's just, yeah, like you said, a matter of putting all the pieces together.
And I think the conversation really does need to start with the providers. I know that the time that you have for visit, there's so many other mandates that we need to talk about. We don't really give it the time it needs. Right. And that's why I mentioned initially, for me, it was always in the childbirth class because I had a little bit more time. That's 17 hours. I can kind of get a 10-minute spiel about why you should consider this. Or I'd always have an inquisitive family because they get all those little pamphlets that you do when you're birthing. And they were like, what's this one, Trinisha? Like, what is that? And I'm like, okay, let's talk about that. But we should really consider trying to, I don't want to say market because, but let them know about this option because people don't. And I know we should wait for pregnancy, but to be honest, we need to discuss these things before.
Right.
People need to be having the decision. People need to know the decision before they actually need to utilize the service.
Right.
Then they'll feel more confident about their choice versus let me see, like, it's like, well, no one else did it. Well, why should I? Versus I know this is something I should do and I want to do it.
Cool. Well, yeah, I'd love to move on to our next topic, which is around birth centers, doulas, midwives, and accessing them and just general accessibility. Where are birth centers and midwifery more common practice? And I know you mentioned in New York, for instance, it's kind of less common practice to take on midwifery. So what do you think makes it more common practice in certain areas or more accepted? And do you think it should be more accepted than it is now?
Well, one of the things that our federal government has outlined is that some of the cures to our maternal health crisis is really utilizing midwifery care as well as doula care. So once we know that, we might ask ourselves, well, why hasn't it moved forward? There's a lot of nuances there. One is that we don't have enough doulas to meet the need, even if we wanted to. And we don't have enough midwives, of course, to meet the need as well. Then there's also reimbursement for the services in which we're discussing. Right now, doulas, depending on each state, they have their own regulations on if they can be reimbursed from insurance claims. Otherwise, you're asking for people who are a little bit more affluent to now have funds or resources to pay for the services. And that's where some of our issues kind of come in. But back to birth centers, the big challenge with birth centers is regulation. And some states have a little less regulation than others. We notice the states that have something called the Certificate of Need. It's a sort of a set of doctrines that outlines why there is a need for a particular medical facility. This was sort of created in like the 70s to be able to open up more hospitals. And now we apply it to birth centers. And in the states in which they have this, it's a big challenge because it has different schedules of different things you need to do. One is survey the community. Second, go to the other businesses, such as hospitals, and ask for the justification for it. Well, if you go to certain areas, like in New York City, where we only have 2 birth centers, we have 8 million people. Do we need to ask the hospital, do we need it?
Yeah.
I mean, it doesn't really make much sense. And that's a big barrier. And we do know that there are some midwives, particularly in Iowa and in Georgia, that have, I think it's Georgia, and don't quote me on that, but I definitely know it's Iowa, that are suing the state in regards to the Certificate of Need and all the sort of regulations that are behind it. Midwives want safety, and midwives want to make sure that we're protecting the public, but we don't want sort of things that just are sort of busy work to prove our need. And if you're asking us to go to a hospital to then ask them if we are needed, what do you think the hospital is going to say? Oh, you're not needed. We're here. We're right here. We're going to give you those services you need. So that's one of the big challenges. The next thing is we don't have enough midwifery people out there to be able to give this service. I think in the United States we have somewhere around 12,000 midwives. You can't say that every person needs to have a midwife or midwifery care, even if they wanted it, when you don't have enough. Let's look at other countries that are a little bit more advanced in terms of maternal morbidity, mortality, whether it's the Netherlands or let's go even to, France, the United Kingdom. they have midwives, and you start pregnancy as seeing it as normal, and you go to a normal provider, i.e. a midwife. And when we find something wrong, then we send you to the specialist. But here in the US, we start with, oh no, something's wrong. You need to go to maternal fetal medicine doctor or even an obstetrician. And then if they don't think anything's wrong, then you would go see the midwife.
Yeah.
It's a whole different way of sort of understanding health and healthcare. So that's one of the big challenges. And as for doulas, we just don't have enough. And if insurances aren't going to pay for it, then you're asking birthing people to come out of their pocket anywhere, depending on the region they're in, as little as $800 and maybe as much as $2,000.
Right.
And that's not reimbursable. And, having a baby costs, most people estimate $1 million.
Yeah.
So you have to start somewhere on what you can afford. And some people don't necessarily understand the true support that a doula can provide. It's not just the labor support for labor. They also can provide care before you become pregnant, preconception. They can help you in those early couple of weeks. The doulas can also come postpartumly for you. And there's all types of doulas. Doulas out there for when people are end of life, or even when they decide they want to have abortive services. So there's all types of doulas. I don't want to get into all of that now or here, but you need to recognize that it's not just one type of service that they provide.
Right.
And as for midwives, we are very confused in our states because we have 3 different types in the United States. There's a certified midwife and a certified professional midwife and a certified nurse midwife. And every jurisdiction, every state has their own rules about how they can practice. And that only then confuses the public even more. So that's where some of these challenges set in. But back to birth centers, we find that the states that have less regulation or less need of the certificate of need have more birth centers, such as Texas and California. And of course, we always have the people who oppose birth centers and think that they're unsafe birthing spaces. But I need to remind you that most of the statistics that we're getting out about the poor maternal morbidity we have in our country are coming from the hospitals. So, some people say, well, we should count the home birth and the birth centers. Even if we do, and even in some places we are, it still wouldn't equal up. We do have an organization out there called the American Association of Birth Centers, which has a set of regulations and ways in which birth centers can open and be safe. And then these birth centers will then be certified, most of them, depends on the municipality, by another organization that will then regulate, sort of like the Joint Commissions, how different things are happening at the birth center and look at outcomes. If something does happen, there is a way that they review it and make sure things are safe for every person.
So you mentioned, I have a lot of questions. You mentioned the case in Iowa. Why are midwives in Iowa suing the state?
Because the hospital doesn't want them, the certificate of need, doesn't think that they are needed. And so therefore now they're like, well, we've gone to school, we're trained, we are licensed.
Hospitals said they don't need any midwives.
Well, no, not that they don't need midwives. The hospital is another organization that's there. And when you do your certificate of your needs assessment, the hospital doesn't believe it's needed in the community, even though there's no birth centers in the entire state. I don't know what the number of people that live there, but I would imagine you should at least have one in a whole state. None of the states in the United States are that small, but you can't even have one birth center. But there's none. And the hospital is opposed to it, and they're like, no, we're not going to support this.
Wow.
So we'll see where they go. It was just in January of this year that they started their lawsuit. We know how this stuff takes some time to work its way through.
Yeah. No, I remember seeing an article that maternal healthcare deserts are increasing and have only continued to increase throughout the pandemic, especially with Roe v. Wade changes, but also just during the pandemic in general, businesses were shutting down and things like that. It's kind of crazy that then there's no need for a birth center. There clearly is a need.
And that is happening in a lot of our country, whether you're talking North Carolina, whether you're talking upstate New York, anything outside of the 2 hours, because New York State is big, that we don't have enough maternity care providers. Some of it is that we don't have enough obstetricians that are being able or willing to do this type of work. Maybe people choosing other specialties. And we do anticipate there to be, a less workforce that's available. But the same thing's happening with midwives and midwifery. The workforce is not increasing, although people are demanding for it more. So we don't have enough people to be able to work and do that type of work.
Right. Why do you think the United States has positioned birth to be an emergency and you automatically go to an OB and then potentially a midwife versus seeing a midwife first and then seeing an OB when it's necessary?
Well, it's rooted in the history. If we look back maybe as little as 50, 60 years ago, we used to have a lot of granny midwives. There were a lot of midwives of color. And in order to be able to control birth, because you have to remember there is some money being made in it, particularly when you have people who are coming out of slavery, who have a special skill set and can be able to offer care in a certain way, people would rely on the midwives in certain communities. And what did we do? We stripped them of their ability to practice. We said that they're not safe, they're killing people. And then at the same time, we had the rise of understanding how obstetrics, started. And as they got rid of these grand midwives, then we had our births move into hospitals. We became more organized on how we offer obstetrical care. We created a lot of different things within obstetrical care, whether it was anesthesia, whether it was twilight sleep, whether it was hospitals and nursing and all of that expansion. But we never really looked at the midwives and midwifery. And recently, within probably the last 30 years, we've had a sort of surgence of people wanting to go back to more traditional ways where there's less intervention. And then we've had to rethink how we've gotten rid of the midwives. I need you to understand, in all 50 states, midwives don't even practice the same. So when you start with that, I mean, some states, they can't even write prescriptions, and other states, they're regulated by physicians. It's very challenging.
Right. Yeah, it's really interesting because I feel like not a lot of people talk about midwives, or in the US, especially in media, midwifery isn't necessarily depicted. But most of my friends that have given birth who are really interested in evidence-based birth and do a lot of deep diving into research and statistics around birth, they always choose birth supported by midwives because it's like correlated with less interventions and things like that. So if you were to build like your dream birth team, what would it consist of?
Well, I need you, before I even go there, but I need you also to remember that midwives really do honor body autonomy.
Right.
That you are the best understander of your health. And while we want to give you the information that you need to practice and be safe for yourself and your body and your baby, we want you to be able to lead yourself into that direction of understanding your body and what your body is telling you what you need. In order for me to build a good team, it would be to have other midwives that are open to understanding midwifery in its truest sense, to be able to be safe within the parameters, but at the same time, give people the respect that they need to make decisions about their body. And one of the problems in our current maternal crisis is that we don't give people the opportunity to make decisions, that we tell them when they should be induced. We tell them when we're going to give them this. It's not a conversation. You're not dilating. I'd like to know, is it possible we can consider using some medications to move the process along? It's like, all right, we're going to give you this now, and now it's not a conversation. I'm going to tell you what's going to happen.
Yeah.
And that's what allows some birthing people to be scared. Some people have had babies in the past and they've experienced a lot of trauma. And sometimes I get those families that will come to me and tell me how they're scared. Like it's like post-traumatic stress. Just talking about a hospital brings them to a whole new level of they just can't move forward. So it's building a team that understands those things, understands people's lived experiences, understands the underhanded racism that can sometimes go into our medical society, and maybe be able to listen to the birthing person or the person's desires and try their best to be able to give them the care that they need and they deserve.
Right. So if someone found out that they were pregnant today and asked you, should I choose an OB, midwife, doula? How do I choose? Which ones? Should I do more than one of them? What would you say?
I would first say that you need to first search within yourself to figure out what you think is best for you. I would start with, good diet, good hydration, good rest, and then feel what feels right for you. Having an unmedicated birth is not for every single person. And I'm not going to sit here and tell you every person should. Some people will need medication, whether or not you've had other traumas in your life. Sometimes the whole birthing experience and the pain that's associated in that vaginal area can be a big trigger for them. But I would tell them to do your research. Start with, one that you mentioned, evidence-based birth. I love that. Maybe Birthing from Within. Ida Mae Gaskett's book on maternity and childbirth. There's a lot of good reads out there, or good podcasts that you can read and understand. But to be honest, I wouldn't want them to start doing that research when they find out they're pregnant. I want them to start doing that research earlier.
Right.
I remember a few years ago, I was watching a YouTuber who was searching for normal birth. And at this time, of course, I was a midwife. And she was doing her work even 3 years before she became pregnant about understanding birth centers and birth and what her body can do. And a lot of her friends were like, oh, that's crazy. Why would you do that? You can't wait until you're pregnant and to then decide.
Yeah.
I mean, most people do. But then they wonder why they only got 40 weeks to get it together. It
Right.
may not be enough time. I think you should be thinking about that. It's really as soon as you get your menstruation, as soon as you start understanding your body. And that goes not just for the people who may identify as women, but also for the partners that will support them to understand birth options and how you can be supportive of that person if that is what you should choose. Because not everybody's going to choose birth. Like you mentioned, abortion or other things like that. So when people tell me they're pregnant, I'm like, oh, okay. I don't want to be happy for you because maybe this is not a happy time. I don't know what circumstances might have led you to this pregnancy. And I don't want to be sad for you because this could be a happy time. So it's how do you feel about it? What are you thinking? What is your heart or your soul telling you about this pregnancy or your journey or what is next for you?
Okay. Super interesting. Yeah, so you mentioned doulas and midwives, and especially how that can play a factor in reducing maternal mortality in the United States. So currently, are most doulas and midwives covered by insurance? And if not, how would you recommend families coping with that? Do you think it's a really necessary expense that they should go after? How do you think about that?
So that's a good question. It really depends on the state that in which you're in. We're right now sitting in New York, in which there are, particularly in New York City, there are certain allowances that I thank goodness our mayor has looked into in terms of doula coverage. And there's certain allowances that some of the public insurance, i.e. Medicaid, will pay for the services of midwifery. And we also have certain hospitals, usually our public hospitals, that are well-staffed with midwives. So in some ways in New York City, we're in a different area versus other states that in which don't have the access to midwifery care or don't have the access or their state or municipality doesn't have coverage for doulas. So that can be a big challenge. Most insurances are not going to cover a doula. Just going to be honest with you.
Yeah.
We do have a handful, but I would not say most of them. So I would say if this is something you want, I would ask for it. Ask for that doula you need and then lean into your family. People want to buy you all unnecessary baby junk. You need to survive this birth and you need to have a good experience. Maybe that money would be well spent instead of, the $2,000 on the stroller, that we can put some of it towards a doula to be able to have the care that you want or the support that you need.
Right.
I do recognize that not all midwives are the same. And not all midwifery care is the same. So for some folks, they really do want the midwife visit. Most midwives will spend 20 to 30 minutes, maybe even as much as an hour, talking with you, finding out about you and your life and how they can best support what it is that you'd like to have for your birth experience. Or in general, GYN or infertility or something else. Because midwives don't just do birth. We do other things, whether it's primary care or something else kind of going on. But they really do typically spend time with you, try to remember exactly it is what you've asked for, and then try to get the resources to be able to understand what you need to be able to help you out. And we are part of the complementary medicine. We believe most times in acupuncture and other things like that would be able to help you to be able to be the best person you can. Yoga, meditation, all those other things. Sort of like a naturopath would.
Right.
Midwifery care is encompassing of all of that. But each midwife is different. Some midwives are more medical and they're going to, stick with the books and to the facts. But it's finding that provider that works good for you. What I tell most birthing people is interview a few. Most will have open houses times or consultations. Figure out which one works best for you. Or maybe ask a friend that maybe had a doula or a midwife and say, what was yours? Let me start with that person as a resource and then lead yourself on out from there.
Cool. Yeah, when I Google midwife, I think a really common question amongst pregnant parents is what is the difference between a doula and a midwife?
Oh, okay. So now that's a different thing. So a doula is not a clinician, meaning that they're not going to do anything medical to you. They really are there for emotional and physical support and information. Versus a midwife is a clinician. We will listen to your heart and lungs. We will diagnose you with things. We can prescribe medications, different things like that. That's the big difference. We're clinically based, and we actually do deliver your baby.
Right.
We won't get into too much about free birth or doulas working outside of their scope of practice or other things like that. But for the most part, they're not clinicians. They're not supposed to be.
And then what's the difference between a certified nurse midwife and a certified midwife?
So a certified nurse midwife and a certified midwife are the exact same thing. We go to the exact same school. We take the exact same tests, except it's the road that led us into midwifery. Some people enter midwifery with a nursing degree and in which they have the nursing background.
Right.
And the certified midwife doesn't have that nursing background, but they will take classes in midwifery school to bring them up to speed to the medicine that they need to know about, quote unquote, nursing things, vital signs, understanding how to do a physical assessment, different things like that, in order to get them prepared to be a midwife.
Right.
And in 7 different municipalities, certified midwives can practice, and certified nurse midwives can practice in a lot more. Even though certified nurse midwives have been around for over 20 years, it's taken a long time for each state to change their laws, and that's a little bit more of a work. Versus a certified professional midwife, you may know of those as ones that are specialized in community birth, like birth centers and home birth. They do not work in hospitals.
Right.
In different areas, they can prescribe medications, but they are clinicians, and they do deliver babies, and they go a different route to midwifery. Usually they'll take classes and then take a competency exam, and they specialize in community birth. Most times the ones working out of hospitals are certified nurse midwives or certified midwives.
Okay. And then I think another really common question amongst pregnant parents is what's the difference between a birth with a midwife versus a birth with an OBGYN?
Well, the big thing to keep in mind, the obvious thing, is that a midwife does not do surgery. It doesn't mean we don't first assist, and help out with surgery, but we don't literally take you into the operating room and do a cesarean. So that's one of the biggest things. The obstetrician will go to medical school and will learn obstetrics, and particularly with things going wrong, whether it's forceps, vacuum, stuff like that. And a midwife specializes in what is normal and usually is well trained on a regular, normal vaginal birth. But we can, again, assist, which makes it very gray and confusing, because we can assist the obstetrician when we're doing surgery in certain areas, definitely not at home or the birth center. So that's why it gets a little bit confusing. But most times a physician is a well-trained specialist. They go to medical school for 4 years. They take 4 years of residency and then sit for an exam, which shows a certain amount of proficiency in education. And their focus is not necessarily all the time on the alternative health things, the feel-good things like your chiropractor or your massage or your daily meditation and asking you about things about your lifestyle. Their focus is usually a little bit different. It's like you have a medical concern, I want to diagnose it and treat it and moving on. But it doesn't mean that there's not what we call medical midwives. And some of our obstetricians can be a little bit more inclusive and supportive of the more natural ways and talk with their clients about those things as well.
Right. Okay, interesting. I think a really crazy piece of history that pregnant parents should know about is vacuum usage and also the twilight births that you mentioned earlier. So do you mind explaining what a twilight birth is and how it's changed since it was put into common practice?
Well, I feel like it was sometime in the 50s that in which we would have birthing people come into labor. Usually their partner would remain in the waiting room, wouldn't know what had happened. We give them high doses of medication. They would be really out of it. And when it was time for the delivery, they would take them in the operating room, keep them on this high dosage of medication, and they would use instruments, forceps, usually to remove the baby when it's time to the delivery to happen. And moms would wake up maybe a couple of hours later and have their baby in their arms and not be the wiser of what had happened.
So why do you think that's not so much common practice now?
I think people want to be aware of what's going on with their birth. We've had enough scary Lifetime movies of people switching babies. You're like, how do I know when it's all those babies there? I think people want to be aware of what's going on with their body. They want to know what's happening. But I got to be honest, sometimes I have talked to people who have experienced trauma and they don't want to see anything. They want to be anesthetized, or they want literally surgery to remove their baby because of whatever previous trauma that they've had. So we need to keep that in mind, that every person's individual experience is different, and we need to be open to hearing what they need to be able to help them through it. Because some people would have trauma, they do not want to experience any more trauma down there.
Right. Yeah. A few days ago, I saw on another podcast, these two parents were talking about how they didn't understand why she wasn't fully anesthetized for her C-section. And then an OBGYN responded and said it's because I think it's called a depressed baby when they come out being affected by anesthesia as well. So yeah, in your opinion, why aren't people fully anesthetized and put under when they're doing a C-section?
So when you say fully anesthetized, I would assume you mean like literally sleep and you don't know what all happened. There's more risk when we have higher levels of anesthesia, not only just for that person, like when you do general surgery, for you to wake up, there's always a risk that maybe the anesthetic was too much and it may not allow you to wake up as easily. And also you have a baby and you have a lot of circulation. And if that oxygen level decreases to the baby, that could be devastating for long term.
Right.
So most cesareans are not done under general anesthesia. It's only if there's a medical reason or a stat case or we can't place an epidural.
Right.
We usually have the mom still conscious and aware. And for some people, even the tugging and pushing on the abdomen, like you mentioned, can be a trigger or they literally feel it and it's a problem.
Definitely. We talked about, or previously you chatted with me about equitable pay for midwives. So how do you think how much midwives get paid and how much insurance is able to pay midwives? How does pay play a role in midwifery and versus OBGYNs versus doulas, for instance?
Well, one thing that we mentioned earlier was the great outcomes that we are all generally aware of and accept in midwifery care. And if midwives provide such great care, whether we're talking here in the U.S. or another country, where we give good prenatal care, good delivery care, we have great outcomes. Why are we paid so little for the work that we're doing? So that if I deliver a baby and I give prenatal care and I only get 10% of what a hospital gets, when they have poor outcomes, people aren't as happy, not in general, but sometimes they're not as happy with the care they receive. They don't feel as though it's personable. And sometimes we do have some missteps. Why are they getting compensated at such high rates? So when we talk about midwifery pay, I'm just mentioning that, we need to be aware of the great outcomes and why aren't we incentivized to actually be compensating people for those great outcomes?
Right. Do you think that in other countries like the UK and the Netherlands, their incentive structures are different and that's why they're more prevalent?
No, I just think the structure was built differently. They didn't have the inherent racism that ran through, unfortunately, our colonization here and sort of disrupted what could have been something great. But we were already built on a foundation that wasn't that stable anyway. But I do believe that in the Netherlands, not only do we know that they're happier people, there's something else that goes on with the maternity care services, not just midwifery, but also giving birthing people time off to nurse their baby and to be with their baby.
Yeah.
Here in the U.S., we don't really give any compensation. We have some states that give 6 weeks of care, 6 weeks of pay at maybe 40% of your salary. How can you nurse a baby, bond with a baby, and be there? And how can the partner? Because some jobs don't even give the partner any time off. And as I understand it, a lot of times they give them 2 to 3 years off. They also give them, it's a special thing they give them. It's sort of like a doula, but it's someone who specializes in postpartum care that comes to their house, teaches them how to parent, teaches them how to care for their baby, talks about lactation. And this person, as I understand it, is there with them for about 2 to 4 months. And this is regular, acceptable care.
Right.
It's not something you got to pay extra on.
Yeah.
So there's just something to be learned there.
Yeah, I read this article. I don't think it was the Netherlands. I think it was Finland.
Maybe it's Finland.
In Finland, they have. Well, no, I think your story's about the Netherlands. Yeah. But I read about in Finland, new parents get basically a baby box, and it's kind of similar to the concept of bump boxes in the United States. But they basically get a box with a bunch of newborn materials, and the box itself can actually double as a crib, which I think obviously isn't necessarily the safest option ever. But it's just really interesting that their government is so forward thinking about what people need. And it includes, I think, like pretty much like most necessity, like even like small outfits. And I think there's like little pacifiers and diapers and things like that. So it's just like a full set of what new parents need.
Yeah. This is what we should be considering here in the U.S. But you got to remember, most people don't want to pay for stuff like that. We have a certain subset that feels like we shouldn't give anything out for free. But, the health of a nation is based upon their maternity outcomes as well as their newborn outcomes. So even though we happen to be one of the most richest nations, we have some bad outcomes. So we need to really think about what are we willing to give?
Right.
And I'm not a politician. I don't know what those are, but we need to really think about that in order to improve it. Because the statistics from 2020 to 2021 are worse in terms of maternal morbidity and mortality. And they're even worse as we're starting to enter into 2023.
Right. Yeah.
So it's not getting better.
Yeah.
And if we keep doing what we're doing, it's not going to work. And we can't be like some elected officials that say, just don't count the people of color. That's not going to solve our problem.
Yeah, I think what you mentioned around the health of a nation, their foundation is in maternal health is really interesting. I recently read Melinda Gates' book, The Moment of Lift, and she talks about why maternal health is really the core of, a general indicator of the health of a nation, because it's really how children are raised, how they perceived their own health and their parents' perception of health, and that even changes, like, for instance, grown men's sense of their own health because it's how they were raised, and it's really all based in, like, how their mother was treated throughout birth and how they perceive women's health. So, yeah, it's really interesting, and I think not discussed enough.
It's not. And we need to think about what we're doing here. I mean, we have a new legislative law called the Omnibus, which is looking at maternal outcomes, particularly paying for more midwives and different things like that. That one has been on the books, I think, almost 2 years waiting to pass. We'll see if federally we will. And it may allow for the funds we need to be able to start to solve this crisis. But until we put money and energy into fixing it, we're going to still be sitting where we're sitting.
Right. Yeah. So I think we chatted about maternal mortality, but not a lot of people even know what that means. But basically, how would you describe the maternal mortality crisis in the United States, and what do you think is the solution?
Well, I would describe the crisis as being it's devastating when you think about people that are dying based upon preventable causes. That means we have a medication, we have something that can solve it, something to prevent it, something to diagnose it, but we're doing nothing. If this was happening for any other disease processes, we would definitely make better changes here in our country. How do I think we should solve it? Some of the reasons that have come out from different agencies, from the Centers for Disease Control and National Health Alliance, a lot of other, formidable people have done research, is really we need to look at making sure that, one, we deal with the issue of inherited racism and how it's affecting the maternal crisis. We need to look at having providers that are similar to the people that are caring for those birthing people. Because sometimes when you have a provider that is similar to them, whether it's an obstetrician or it's a midwife or a doula, there's somebody that's hearing what this person is saying and can then be their advocate or be able to be a resource to helping them with whatever concerns they have. So that to me, even though I love midwifery and midwives, we need more obstetricians and gynecologists that are from certain communities to be able to literally hear what birthing people are asking for.
Right.
And that to me extends also to our LGBTQ. We need providers that are sensitive and understand their needs as well. I would also say that we need to have more coverage, medical coverage, healthcare coverage for doulas and midwives that pays equitably. You cannot ask a doula to give care for a birthing person for 3 visits, be with them for 2 days of labor, go see them twice afterwards, and pay them $300.
Right.
It's just not. They can't sustain themselves on that.
Yeah, definitely.
So therefore, people are going to burn out or not going to do the work, one of the two. And right now, we have people not wanting to do the work.
Right.
Even if we have enough trained, they don't want to do the work. I think we need to think about some of the policies we have set, particularly the certificate of need and most municipalities, to be able to eliminate that so we can get more birth centers open. We do know in general birth centers have great outcomes. I'm not going to utilize our time here to look that up, but they do. And I think we need to have that access available. We need to also consider the federal government giving money to midwifery schools for graduate education. We subsidize obstetricians and residents by graduate medical education, by paying for 4 years of training. We don't do that for midwifery. We really need to rethink that.
Right. Who decides the certificate of need in each state and what kind of healthcare they need?
The State Department of Health usually is the one that oversees that.
Okay. Interesting.
And most times it's run by a lot of lobbyists, the hospital organizations, and health insurance carriers that are looking for their better interests.
Okay. Interesting. How much does a birth cost in the United States, and how much do you think it should cost?
Depends on where you're at. I mean, like I'm more familiar with the New York area, but I mean, some parts of our 50 states, you can have a home birth for as little as $3,000, and other parts can cost you as much as $21,000. And if you're looking at a hospital birth, I know in New York City, because I've had a couple of clients and friends that show me their documentation for their health insurance carrier. For a vaginal birth, it could be as little as $17,000, and if it's a cesarean, as much as $37,000, and that's just normal. Now, if we're talking about NICU, all the rest of that, it can climb. I think what we need to really look at is the time spent with each provider. If midwives have such great outcomes and they spend quality time with these people, why aren't they compensated? And sometimes when I sit down and I tell families about these things, I give good care. I have Medicaid-based patients, not just myself, but other midwives. And then the insurance carrier denies the claim. So you've given care for almost a whole year, hoping to get even $1,000, even $200, and you pay us nothing.
Right.
And that's because of the rules, just like anything else, whether you're talking, an orthopedist, you got to do these things in a certain time period, or we've created a new rule for you. And even, some of the billers out there, like, well, they changed the rules, so now you can't get paid. It makes no sense.
Yeah.
And I get that there needs to be certain steps, but at the same time, you ask for authorization. You say you're going to do certain things, and you don't compensate. So when you ask me about the price, going back to the price, it's hard to say. It really does depend. Now, you do know, I think 3 years ago, we passed a national law, which would allow us all to get access to what a hospital charges for whatever service, whether it's to pull your tooth out, whether it's to put a Band-Aid on. And most hospitals, they do have it available. Sometimes it's like 5 sheets behind their internet services. Like you literally have to dig on their website to find it. But technically, they're supposed to disclose what those costs are. And when you look at those costs that they pay for certain things, it will blow your mind.
Right.
The average birth at a birth center, usually depending on where the part of the country is, can range anywhere from as little as $4,000 to as much as $10,000. If we have such great outcomes, we should be compensated at the $17,000, like the hospital.
Yeah.
The person stays with us, they are happier, we have great outcomes. Why are we compensated less? Because we're not a hospital.
Axios recently published an article on which states are costliest to give birth. And in the U.S., across the board, they said the average or the median cost allowed for giving birth is $12,968. In Alabama, it's as low as $7,841. But in Alaska, it was pretty pricey. Alaska, California, New York, Massachusetts, Pennsylvania, New Jersey had some of the costliest births in the United States. And Alaska had $21,526 as the median cost allowed for giving birth. So where do you think those differences between the states, why do you think that happens?
I think it happens based on geographical area. I do know a few midwives up in Alaska, and what I was told is that because of the terrain, it's colder, they can't get as many providers, they typically pay a little bit more. But I even recall this when I used to be at the hospital, some of the residents would go to certain areas that in which they would pay more for the obstetrician because there'd be less people available, which makes sense. But at the same time, a city like New York, where we have 8 million, like, I don't understand it, but we still have people with poor outcomes.
Right.
So I don't really know how to clean that one up. I'll have to leave that one to the politicians.
Yeah, definitely.
I mean, in general, we're not paid. It's just not compensated enough. And as most people know, inflation has happened. And to be paid the same rate that you were paid 10 years ago when everything else has gone up, this doesn't make as much sense. But that's what sometimes does happen.
Yeah. On average, how much does a midwife cost and how much does a doula cost?
So it depends on if you're going to a hospital and you're staying in network, most times your insurance carrier will cover it. Whatever your deductibles are, that is what it is. But a doula, most insurances, again, are not going to cover it. So in most metropolitan areas, it's going to range anywhere between as little as $300 and as much as $2,000 for doula services. And a midwife, if you want, a midwife that is private, that will deliver you either home, hospital, or birth center, most major metropolitan areas is going to range anywhere between $8,000 to $17,000.
Okay, interesting. Yeah, I'd love to move on to lactation. You mentioned you're particularly passionate about lactation, and so I'd love to get your takes. I know lactation is something that I feel like most parents are confused on because they spend so much time trying to just get through pregnancy and figure out the birth and plan for birth, and then postpartum is usually neglected. So yeah, I'm super excited to chat about it. So thinking about breastfeeding, if you have recently had a baby, how do you get a good latch, and what does getting a good latch even mean? Why is it important?
Well, what I say is let's start before the baby comes out. We need to really call your insurance carrier because, again, lactation may not be covered. And if it is, who's in network that provides lactation services? Have a prenatal lactation visit. Some people have had different breast surgeries. Some people have had different issues with previous pregnancies in terms of production of milk and different things like that. I would encourage you to have that conversation before you even ready to push this baby out. Then once the baby comes out, particularly if you're at a hospital, they usually do have lactation help, or the nurses are well-versed on lactation to help get that first latch on. The big thing to keep in mind is when babies are born, we should try our best, unless there's some medical issue going on, to get that baby on mom's chest immediately from the birth, skin-to-skin contact, to allow that mom to have that great letdown and start to bond and nurse that baby. That would mean that we're not going to have the cell phone, that we're not going to be talking to our friends and family members, that mom really needs to be quiet and one with that baby. Because when baby comes out, then we're calling, we're emailing, we're like, no, you have to be quiet and be one with that baby. That golden hour is really golden. Babies will climb up on mom, get on the breast, and start that first latch. You should make sure that, within that first hour to 2 hours, baby has their mouth open nice and wide and can really get their mouth over that breast tissue. And that's if people want to breastfeed. Some people only want to chest feed. Some people don't want to do any of it. Maybe other traumas may be reasons, or whatever personal issues they have. So I'm respectful of, people making their own choices, but to be aware of, we have to start before we become pregnant, know who that person is going to be to help support us at the hospital, birth center or home, and then make sure that you have those resources there.
If you're pregnant, what does a good latch mean?
It means that the baby has enough tissue in their mouth where you will hear the swallow, you will see their cheeks go, you will see, maybe depending on the area in which the baby latched on, you may even see the baby have the milk come down, and you'll hear that latch kind of go down. And some people just won't have a good latch because of whatever issues they've had with their breasts and surgeries or other things kind of going on. But that we have a good suction, there's a good sort of opening of the baby's mouth where there looks like almost like a C type area over the baby's mouth. I would also encourage people to go on YouTube. It does have a lot of great resources. Look up, good latch or proper latch, and there's videos there where you'll be able to see that happening if you're curious enough. Yeah.
Right. Why is it so important that babies get a good latch if you're breastfeeding?
Well, because sometimes if it doesn't, then you won't be able to get the baby to drain the mammary ducts, the ducts that produce the milk from the top all the way down. And if they're only on the front, sometimes it'll cause cracked nipples, or they won't be able to sort of sustain that latch and constantly be on and off. The other thing to keep in mind is babies can have different things going on with their tongue, whether it's, some sort of issue going on with how their tongue is and tongue-tied or something like that. Yeah, or there could be just poor suck. There's a lot of variances of normal. Not that it's wrong, but it's just different things that can happen differently.
Yeah. If you are breastfeeding and you have cracked nipples, how do you treat that?
Every person deals with a little different. Sometimes we encourage breast milk to be placed on the nipple and let the nipple be exposed to more air. Make sure it's drying out in between the feed. Make sure we got a good latch, because the poor latch could have caused the cracked nipple. So different things like that. Cabbage, sometimes cool cabbage placed on the nipples can be able to help. And then nowadays we have a lot of Lanasil, different creams to be able to help lubricate the area as well.
The vegetable cabbage?
Yeah,
Okay.
Like you would cook soup.
Oh, wow. That's awesome. If you're currently breastfeeding and you have a clogged milk duct, how do you think you should best unclog it?
Depends on where you're at in that nursing cycle. Sometimes your baby can be able to be or the age of the baby. If it's real, newborn, maybe not so much. But usually a bigger baby, maybe a few months, or you've been breastfeeding a little bit of time, they can actually help to clear out that. You could consider manual expressing the milk, warm compress, different,
Okay.
There's also things.
Interesting. When is the best time to breastfeed your baby, and when should you start to think about introducing formula or other things like that?
Well, I think, and again, that's up to you, your choice. You should start breastfeeding your baby as soon as it comes out. I mean, not literally 2 seconds, but, within the first 2 to 3 hours of life. And then, baby leads the feeding. Is it every 15 minutes, every 30 minutes? Let's not get caught up on the time. Every baby's going to be different. Just like, not everybody goes to college at 18, so give your baby a little bit of nuance in terms of how often you should be nursing this baby and how long you should. Meaning that at the actual feeding, should it be for 15 minutes or should it be for 30 minutes? It all depends. Every authority has their own rules of how long you should breastfeed the baby. For the most part, the American Academy of Pediatrics says 6 months. Most families that are successful at breastfeeding want to do it for at least a full year, if not as much as 2 to 4 years. I mean, at some point, this baby's not going to be breastfeeding. I mean, some people are like, oh, the baby's 8 and it's breastfeeding. Yeah, it really never happens. I mean, at some point, baby's going to want solids and move on. So you asked about solids. It depends on your pediatrician and what's going on with your baby. But most babies, somewhere around, 3 to 6 months, will introduce some sort of cereal type device or foods that are mushed up, because nowadays we have all these great things that grind up foods and stuff and make for babies to supplement the breast milk.
Yeah. I remember seeing this Time magazine cover of a boy, I think he was 7 or 8, and he's still breastfeeding. And one of my friend's moms was actually her lactation consultant. So why do people breastfeed so late into their baby's life, even up to 7 or 8 years old in the rare cases that it happens?
Well, I think there's some amount of bonding, cuddling time that is intimate between the mom and the baby and not a nutritional always base need. And as long as mom and baby or a child or adult or whatever, however old this kid is, are okay with it, I don't think we should be judging them.
Yeah.
Even 8 years old and the kid wasn't doing it at 10, like at some point they are going to stop. But we as society, we're going to judge and point our finger and shame that person. So if they want to nurse their baby at 4, then let them nurse their baby.
Yeah.
They're not going to be doing it at 10. I mean, at some point they are going to stop.
Yeah. I've read about alternative uses for breast milk, for instance, on your baby's skin if your baby's irritated or eczema. So how else can you use breast milk besides actually feeding the baby?
Acne, any rashes you have. Some adults even use it for, even male adults have used it to build protein when they're exercising. There's a lot of great uses for breast milk. And on the internet, people sell their breast milk.
Yeah.
Particularly once we had the vaccine available. That one was like breast milk with vaccine, it's like people wanted it even more. But, there's a lot of different medicinal uses that people will use. Eye infections. I'm trying to think of some more stuff that comes up that people will put, because it has antimicrobial properties. So putting it on something that seems as though it's maybe infectious or have a cut or some sort of bacteria, it'll be helpful for that.
Okay. Is there a black market for breast milk? How much does breast milk sell for?
I've been told as much as maybe $25 an ounce.
Wow.
Yeah.
Wow. Yeah. I've spoken with surrogates who donate their breast milk, but I've never heard of selling it.
Yes, you can sell. I don't want to name any commercial-based places, but there's places for people to purchase breast milk. Or I got to admit, sometimes it's randos that will email midwives, you got breast milk, like I store other people's breast milk. But yeah, people will look for it.
Okay. Interesting. How long can breast milk last after it's pumped?
So we suggest that if you know that you're going to store it, and particularly you're going to use it in the next 2 to 3 days, and sure, refrigerator is fine and some sort of clean device to be able to get, feed it back to baby. But if you know that you're not going to need it for 2 to 5 days, then you probably should put it in the freezer, like a refrigerator freezer, not because most people don't have deep freezers, and like that, it'll stay for about 6 months.
Okay.
And you should put a date on it so we can kind of know how long it's there, because after you start storing it up, you don't know which one on the bottom was which one on the top.
Yeah. If you're currently breastfeeding and you warm up breast milk, what is the rule of thumb for what temperature your breast milk should be?
Should be room temperature.
Okay.
Just like any other formula you're preparing, you don't want it too hot or too warm.
Right. If you're currently breastfeeding, when should you start pumping and thinking about pumping?
Well, we kind of want to make sure that the baby is well established on a good latch, like we mentioned several times, and that you're producing enough. So most folks, that would take at least 6 weeks.
Okay.
If we could wait even longer, we'd be happier, but most people 6 weeks. But I do have a lot of eager parents because some people only get 6 weeks off for work and they need to get back. And usually by week 1, they're starting to try to pump and store and everything like that. And, sometimes that does happen, but I would try to wait at least 6 weeks.
Okay. If you're currently in your last trimester of pregnancy, do you recommend pumping for colostrum?
No. Because pumping can actually encourage the labor process. It's very connected to the uterus and can start labor. So that may not be the best time.
Okay. What is colostrum and why do people pump for it?
Colostrum is like the first milk that comes. It has a lot of fat in it, a lot of nutrients in it. And sometimes it comes spontaneously as little as 16 weeks of pregnancy without people doing anything at all. But
what should they do then? Just wash away?
Put a breast pad or some sort of paper towel or tissue, and don't encourage it early in the pregnancy because stimulating the nipple will stimulate the uterus, which cause contractions, which can lead to early labor. Okay. So we don't do that unless you are a person who has another baby and you're nursing, the tandem nursing. That's where it kind of gets a little gray here because if you're nursing another baby, maybe you have a 2-year-old or 1-year-old, and then you're pregnant, you will need to, unless you decide you want to stop nursing, you will need to nurse that baby to give the nutrients they need, and at the same time you'll be pregnant. But if you're not, we don't strongly encourage you to just regularly, when you're pregnant, to be stimulating your nipple.
Right. Okay. I've chatted with a lot of parents who talk about mental health in relation to breastfeeding. So if breastfeeding is causing parents mental health issues, what are your recommendations for them?
I say, give yourself a reprieve. Allow yourself to be grateful for your body and your baby, and to allow yourself to buy some formula. Because for some people in our society, it's a lot of pressure put on them to not only have this fantastic birth and experience, because, we're in the Instagram life, everything looks great on the gram. Then your body doesn't necessarily produce enough, or you're having challenges with breastfeeding, and then you don't feel as adequate, or that you can't be there for your baby in the way your baby needs you to be there. Your baby needs you whole mentally, even if that means giving formula.
Right. Okay. Last year, I know on TikTok it was trending that people should dilute their formula. Did you see that?
No.
Oh, really? Okay.
I wouldn't recommend that at all.
Yeah.
Whatever the manufacturer says, that's how you're supposed to prepare your formula.
Yeah. No, it was weird. There was like a trend on TikTok last year where, people were basically, because it was during the formula shortage.
That's why.
Yeah. So during the formula shortage, there was a trend on TikTok that you should dilute your formula. And I guess people saw it as kind of a hack, but why is that so dangerous?
Because most of these companies have designed that formula. Literally, it's a formula to meet a certain amount of nutritional need for your baby per serving. And when you dilute it, that nutritional need is not being met.
Right.
So if it's supposed to have a certain amount of iron, the iron is not going to be the same amount. It's a certain amount of vitamin D. It's not going to be C or whatever it is. So I would not encourage you to dilute the water. Right. Dilute the milk.
Well, thinking about mental health, how should you prepare your body mentally for having a baby, and what kind of mental health-related precautions should you take after having a baby too?
Well, I say to start first with knowing what's going on with you and your mind. If you've had some history of some sort of mental health issues, that you need to get your mind right, hopefully before you become pregnant, and if not in that first trimester, if you are even aware you're pregnant. And get a good team built up, a good therapist, postpartum support, whether it be a doula, a friend, family member, you need that support. Because I have had moms that have run into postpartum issues, and whether it's psychosis or real serious depression. And sometimes it's the not having the support. Because in this society, we've told that most people that you can do it all.
Right.
You can do it all until you have a newborn, and then you need a little bit of help. So I would say, again, as soon as you find out you're pregnant, to get your team together for your mental health services and that therapist together that you feel comfortable with, so that maybe you'd only have maybe a couple of visits in the pregnancy. But if something happens in the postpartum, it's not like, let me figure out who I'm going to call. I don't know if I like this person. Well, you like them because you've seen them twice, or I didn't like them, so I'm moving on to the next person. Yeah. That's what I would definitely say. And if you can, or you choose to be, single by choice or not be with your partner, still build a village. See what friends or family members are out there. Create social groups, whether it's on Facebook or other mothers groups, or based on your area. There has to be some sort of groups there. And I tell other people, consider religion, going into a church, a mosque, whatever, a temple. There are always older people there that want to be able to help you, to be able to help support you. And I'm quite sure someone there would be like, oh, yeah, let me see how I can check in on you. Sometimes the elderly, retired people, they don't have much going on. They love to know what's going on with new baby. Oh, why wouldn't I want to come over and help her? Yeah. So think about that as well.
Okay, awesome. My last question is, I know you're building a birth center for BIPOC communities. So if someone is currently pregnant and a part of a BIPOC community, what would be your top 3 tips for them in preparing for pregnancy?
I would say definitely take a childbirth education class. You need to be educated on what your body's going to do and how labor is going to go. And a complete class will be a big eye opener to you knowing what's going on. Secondly, choose a provider that you feel most comfortable with, even if it's a physician, which I think a lot of our physicians are great, but make sure you feel comfortable with that team that you're choosing. If you don't, move on. Find somebody else who will listen to you, hear you, and support you. And the third thing is, I would definitely plan more for your postpartum. We put so much energy into this birth, but once this baby's out, sometimes some people will need more support than they think they need. So how are you going to build your team around you to help support you?
Right. How important do you think it is that your birth team is the same ethnicity as you?
I think it's really important, particularly for our BIPOC people.
Okay.
And if you can't find them, because I understand some parts of the U.S. we don't have a lot of other ethnicities there, then find somebody that you at least trust. And make sure they know you by name. I always sometimes tell people, even when you get surgery, I need you talk to those people in the room. Do you know my name? If you don't know my name, then don't start operating. You have to know. I need you to know that I matter and that I am important to you.
Right.
So that this way they'll give you the support that you need during any procedures.
Right. Okay, awesome. This was a super insightful conversation. Thanks. So I really appreciate you coming here today. And yeah, I'll definitely plug your birth center. That's really, really exciting. Congrats on opening that. Love what you stand for in general and just getting pay equity and thinking about costs. So yeah, that was really insightful.
Yes. And when you're ready to, whatever you're going to lobby for some sort of cord blood, let me know.
Yes, I will.
Because I want to get, that is something, because to me, I think people of color need this service.
Right.
And so we need someone to write some bill federally. I'm being honest with you.
Right.
To move this forward.
Yeah.
We can't piecemeal it. It has to be federal.
Yeah, definitely. Yeah, especially because Black folks in particular, it's hardest for them to find a cord blood match if they're looking for stem cells. So yeah, I make a lot of content around being mixed race and BIPOC and things like that.
You get it.
Yeah, my family couldn't find a match for my brother for cord blood stem cells. And we think it's largely because we're mixed race and we're half Chinese and half white. So it's not even that crazy of a mix. But Be the Match has this whole metric around how difficult it is to find a cord blood match if you don't have your own stem cells. So yeah, it can get pretty dicey there.
Yeah. And if we had something federal, it would also help you guys out because you would be able to be paid.
Yeah.
I'm just saying, it's not being altruistic, but it really would make a difference.
Yeah, definitely. Yeah. So that's why I think it's so important for POC and mixed race folks and BIPOC communities, if they're pregnant, to really consider keeping stem cells from their umbilical cord and placenta. Awesome. Cool.
All right. It's been a great conversation. So I will definitely follow up with you with some email.
Yes, definitely.
Thank you so much over there.
Okay, awesome.